Right. So based on these risk strata, now the FIT trial is looking at a number of the main emphasis is on reduction of toxicity by reducing the toxic chemotherapy while maintaining comparable outcome results. So once again, I'm restricting myself to hepatoblastoma. This tumor, the protocol deals with hepatocellular carcinoma as well, but the relevant arms for the hepatoblastoma are for the very low risk tumor, where you would get upfront resection followed by 2 adjuvant courses. So now you're randomized to 2 adjuvant courses versus observation, and you will see what the outcome is. So you will spare these children 2 courses of cisplatin, which of course has its impact, which we will talk about in a minute. Then coming to the low risk tumor, which become resectable after 2 courses. So, previously the standard was a total of 6 courses, 2 or 4 pre and then 2 after. So what they are testing now in a randomized fashion is that if you are able to resect the tumor after 2 courses, instead of giving them 4 adjuvant cycles, you randomize them between 2 versus 4. So again, you'll be able to, if it bears out, you'll be able to spare a subset of children 2 courses of autotoxic chemotherapy. Intermediate risk tumors, there's a comparison between the American C5VD regime with 5-FU, etc., and versus cisplatin monotherapy. And very high risk tumors, the resistant metastatic disease, in which you will test whether the vincristine irinotecan and carbodox versus carbo-ETOP carbodox are to be randomly assigned to patient population. So this is what is ongoing at the moment at the chemotherapy. So just before we move on from clinical stuff, CUPEL-6 trial was the trial which looked at whether we can spare children the autotoxicity that is associated with cisplatin use. Cisplatin is used in a very high dose, a relatively high dose in hepatoblastoma treatment, but the question was whether the STS, sodium thiosulfate use, would be able to spare that while maintaining the outcome. Because one of the valid concerns is whether with the autoprotection, is there a tumor protective effect as well? So what they did was they gave children, I won't go into the details in the interest of time, but there was an STS group and a cisplatin alone. So they found that the STS group had hearing loss 33% versus cisplatin had 63%. So there's a significant autoprotection with sodium thiosulfate. PEDMARK is the FDA-approved drug, but I don't know whether those living outside the US are restricted to PEDMARK brand. Sodium thiosulfate is not very expensive if used. So I'm not advocating it, but I keep wondering about it. So, and the outcome in terms of the tumor outcome was absolutely comparable with no significant difference. So now coming to what else is out there in terms of what's going on. This is a very interesting study on the epigenetic footprint, which stratifies the tumor at a molecular level. So at a genomic level, they are able to identify some poor prognostic factor, for example, 4q deletion and 18 deletion, 17q gain, etc. And with transcriptomic study, the RNA sequencing, etc., was able to identify, we know that in hepatoblastoma, there's a global dysregulation of the dysregulation of the global RNA editing. And then there's a BL-CAP editing. BL-CAP is a tumor suppressive gene, which is which gets edited and then leads to oncogenesis. Overexpression of the 14q, which is also a poor prognostic factor. And then the methylation study identified the epi-CA and epi-CB two subtypes, which have prognostic implications. So based on those, look at the bottom right Kaplan-Meier curve. They have stratified into molecular risk group 1, 2, and 3, and the prognostic implication is there. And then the check A may be a new therapeutic target for future use. So this slide basically tells you what I've just said, and this is just a detailed description of that. Now, this is another study on epigenetics. So here what they've done is that they've looked at various clinical, genetic, and methylation profiles of the patient. Same group, about 80, less than 90 patients. So based on clinical profile, the prognostication came with age, pretext stage, annotation factor, histology. We know that. So in terms of the genetic profile, they were able to, I'm sorry, it's not predicting very well, even I can't read it from here. So based on genetic expression, the chromosome instability, enhancer and promoter status, they were able to stratify patients. And on the methylation profile, the DLX6 AS1 is a surrogate marker for hypomethylation status. So the older you get, the higher the hypomethylation gets, and the poorer the outcome is. So molecular targets under investigation is the Wnt beta-catenin pathway is one under investigation, which can prove to be a future target. There's a crosstalk between GAP and beta-catenin, which could be a target for mTOR and MEK inhibitors, and then certain others as well a bit further along the line. So this slide just shows you that the GAP and beta-catenin interaction upregulates the proto-oncogenesis, and that can be blocked by mTOR inhibition in the middle of the slide, the green bit. So everolimus, sirolimus, and MEK inhibitors can address that. So that is a potential for chemo-resistant disease. Immunotherapy, not really, because it's a bland tumor, and the sporadically occurring hepatoblastoma does not show characteristics that would make it amenable to immunotherapy significantly, except the FAP related FAP-associated tumors, which have this ability that the cisplatin induces changes which attracts the T lymphocytes in a way that CAR T cells can prove of benefit in this particular subset of patients. But mostly the sporadic hepatoblastoma, according to our current understanding, is not a tumor for immunotherapy. So in summary, the prognosis of hepatoblastoma has significantly improved over the last 30 years. No small thanks to our hepatobiliary surgeons and transplant services, and as well as the successive chemotherapy clinical trials. Intergroup collaboration we have seen has worked and will work further because the more data there is, the more meaningful the results will be. And new insights into the molecular basis are, of course, a gateway to future improvement of outcome. I thank you very much. I'll be open to any questions, but I think we are having question answer at the end. Thank you.
Thank you, Dr. Mas, for an excellent talk and right on time. Our next speaker is Professor Dr. Irfan Ahmed. He is currently working as professor at University of Aberdeen and Robert Gordon University, UK. He is also consultant hepatobiliary surgeon and director of Research Center at Pakistan Kidney and Liver Institute and Research Center Lahore. He has a rich research background with around 200 peer-reviewed publications. Sir. Dr. Irfan will be presenting surgical management of hepatoblastoma.
Assalamu alaikum, and thank you very much for inviting me to this symposium. It's good to be back in Shaukat Khanum crowd after a year. And that's where actually I started gaining my experience in hepatoblastoma. So I'm not going to go through statistics, but we all know that it's the most frequent pediatric liver tumors, but still 1% of all malignancies. Most of these children will come without any symptoms, and parents will tell us that there is a mass in the abdomen, and that's when we start investigating them. Now, I think we can claim this as a surgical tumor because, yes, oncology helps us a lot, but surgery is the ultimate treatment for this tumor. Now, the statistics shows, which mostly come from the West, that 1/3 of the patients can be resected at the time of diagnosis. 60% of the patient hepatoblastoma is localized but not resectable, and about 10% of patients present with metastasis. But still, like I said, surgery is the cornerstone of management, and complete resection is crucial for cure. So we are going to concentrate on surgery, quite easy. Either take the tumor out or take whole of the liver out and put a new one back in. So things have evolved a lot, and I'll show you the improved survival rate. Lots of historic milestone. Dr. Ataur Rahman has mentioned some of them before, but then lots of new developments are coming up also. It's a rare tumor, and that's the problem, because there is not enough samples and not enough data available to do more investigations on this. So a little bit, a bit of a lesson on history. Langenbach, all the surgeons know him. That's the only picture of him available. He described the first successful resection of a liver tumor in a child. We don't know the pathology. We assume that was hepatoblastoma. In 1998, the first literature report came in of possible hepatoblastoma in 1998. But W. O'Sullivan, he performed a lobectomy in a tumor which now we believe is hepatoblastoma. But unfortunately, 1 month after the surgery, patient developed metastasis and then died within a year. And in 1962, the classification of hepatoblastoma came up, which we have heard in the first talk. So there's a lot of data out there. So I'm not going to, so I just tried to summarize it. In 1960, hepatoblastoma was described, but in those 30 years, survival was 45%. Chemotherapy came in, survival went up to 60%, and then surgical techniques improved, went up to 75%, and now we stand at 85% 1-year survival. So that's the improvement. And again, just a summary, when we operate, we have 10% complication rate, 30% recurrence rate, which can happen in the first 1 or 2 years. But now 5-year survival rate is around 60%. This is including all the patients with hepatoblastoma. So some points about surgery. These tumors are huge in size. And I think many people who see these tumors say, no, it's impossible. It's occupying whole of the abdomen. It's not a contraindication to resection. That's the first lesson. Second thing is it has to be done in expert centers. It can't be done by occasional pediatric surgeon. It has to be done in specialized centers. And that's where the knowledge of liver anatomy and specialized equipment is necessary. So we aim to achieve complete tumor resection with resection margin. That's a controversy, and I'm going to talk about this later on. And anatomic resections are recommended, not just taking the tumor out. We have heard about chemotherapy before, but it helps us a lot because neoadjuvant chemotherapy makes tumors smaller, so it occupies less area. It becomes more solid. There is less bleeding, and then it's more demarcated. It's very, very clear how it stands out. So it makes it very easy for us to operate on these tumors. And then we talk about micrometastasis in lungs. We will again touch this later on. Now, planning for surgery is quite interestingly long process. These patients normally come either in primary care, in our hospitals, mostly to pediatricians. They refer them to pediatric surgeons, and then they refer to HPB centers. We take them to MDT where it is discussed. I know in Shaukat Khanum, there is quite an extensive MDT workup for these patients. So oncologists normally take over, or pediatric oncologists take over care of these patients. And after discussion, shrink them down and then bring them to us. And we act as technicians only, basically, take them out and refer them back to oncologists again. So as I mentioned, not only good knowledge of liver anatomy is essential, but a high quality imaging is essential. We exactly need to know where this tumor is before we start planning for surgery. And pre-tax system has been discussed, but for surgeons, it's very, very important. And I'm going to just go through it in a little bit more detail with pictures. So pre-tax is pre-treatment extent of disease. So for surgeons, it's important to know either it's pre-tax 1, 2, 3, and 4, that how many segments of the livers are involved. So that's the conventional anatomy of the liver on this side. But if you start from the top, 3 tumor-free segments is 1, 2 contiguous tumor-free sections is 2, 1 tumor-free section is 3, and 4, no section is involved. So that helps us plan our operation. So we do pretext before surgery, and then after chemotherapy, when patients come back to us for consideration of resection, that is post-treatment extent of disease, that how much chemotherapy has helped us shrinking the tumor. So that's where we plan. And Dr. Ataur Rahman has mentioned about annotation factor. Some are mentioned here, but then this is a long list of annotation factor because they do make patient high risk for surgery. And because of time, I'm not going to go into detail, but it's pretext 1, 2, 3, 4, followed by any of these letters, which is V, P, E, F, R, C, N, and M. And V is venous involvement, P is portal vein involvement, E is extrahepatic disease, F is multifocality, R is tumor rupture, C, involvement of caudate lobe or first lobe of the liver, and lymph node metastasis and M, distinct metastasis. These are very, very important in planning for the disease. We went through a lot of 2 and 4 regarding timing of extent of surgery. CCOG approach was do laparotomy in all the patients. And then Sayopel said that conventional was to treat all patients with neoadjuvant therapy and perform delayed surgery. So that was the debate between these two. And then we have heard about CHIC consortium, where all these 4 groups got together. And they had different risk stratification groups before. As you see, there were 4 risk versus 2 versus 2 versus 3. And then eventually they came up with a recommendation, PHITT trial, that they combined all the patients together. Again, remember, it's a rare tumor. So even combining all these trials together, which came from over 25-year period from 8 multicenter trials. And we have heard this before, so I'm not going to go through it. But they defined it in 4 groups: very low risk, intermediate risk, and high risk group. And the slide I'm going to show it to you, we have seen that before, but for surgeon, again, it's important. Pretext 1, the tumor looks resectable, but if you follow it up, depending on metastasis, any of the annotation factor, and resectability, it goes into either very low, intermediate, and high risk. So that's where we start our surgical planning. The pretext will tell us where it is in the liver, and then going up, what's the risk stratification. And I'm not going to stay on this slide because we have seen this before. But in summary, tumors who are very low risk, they go for resection. Pretext 1 and 2 with no metastasis, resectable diagnosis with no annotation factor, and all the other tumors, they go for initial chemotherapy. So that's the summary or take-home message from the surgical point of view. What do we do? And again, I think there are only 2 surgeons sitting in the room. I hope nobody else. So I'm not going to bore you with the details of what we do in surgery. But there are lots and lots of different operations which we do. It all depends on what type of liver area we are taking it. I've just simplified it here. Incision, we all know this. Small child, so we go for transverse incision most of the time. We mobilize the liver. We resect the parenchyma, stop the bleeding. As simple as that. And that picture, you can see There is a hemostatic agent applied at the cut end of the liver. And what we can use is intraoperative ultrasound just to make sure that what we discussed before the operation exactly stands true at the time of surgery. We also use intraoperative cholangiogram, which is injecting dye in the duct because we have to make sure the ducts are stable. And ICG is quite an interesting thing, which I borrowed a slide from Yasser regarding this, that ICG is indocyanine green. We inject it, it is excreted from the body, but hepatoblastoma retains it. So when we look from the special camera, which is available in operation theater, we know where it is retained. So it can be retained in hepatoblastoma up to 24 hours after initial injection. So that can be injected before the operation, but at the time of surgery, we can see where the tumor is. In this case, you can see the tumor in the liver and the lung is highlighted because indomethacin green is retained, and that is seen through a special camera. So there's a new innovation which has just come out. So again, as you can see that in the picture, tumor is well demarcated, stands out, and we can see where it is. So it is presenting itself to us. So again, lots of information about surgery, that if portal vein is replaced, then we classify that as tumor thrombus. Extrahepatic disease is very rare. We see it in less than 5% of the patients. Sometimes we see ascites, but that is not extrahepatic disease. That's not a stage 4, which is considered in many of the other cancers. Multifocal tumors are around 20%. If tumor is ruptured during surgery, which can happen, it is not put in the category of tumor rupture, which we have talked about before, which is a high risk factor. Lymph node metastases are uncommon. Sometimes we see enlarged lymph nodes, but that is not a lymph node metastasis. And lung metastases are in about 20% of the patient, but we don't need biopsy of the lung. And sometimes, because it's such a large tumor, it will compress lots and lots of tissues. And when we see them before surgery or at the time of surgery, due to compression, it can give lots of diagnostic challenges and even challenges when we are taking it out. So I always talk about controversies in management. What is being discussed? So the first thing is biopsy or not. Do we need to biopsy these tumors before they are operated on? So biopsy should be performed before chemotherapy. And I think that's one of the things which has been discussed. Again, it's open to debate. We can talk about that later on. But we do not need to perform biopsy on the operation table. So that should be avoided. That's number 2. FNA should be avoided because it does not give you enough information about the tumor. It's quite a hard, solid tumor. So if biopsy is being performed, then 10 cores of biopsy should be taken and normal liver should be biopsied also. And biopsy needle should pass through the liver, which is going to be taken out at the time of surgery. So these things are carefully planned and discussed before the operation. And so biopsy, yes, needs to be performed, but if you're going for upfront resection, it does not need to be performed. There's a surgical discussion because in most of the tumors in the liver, we now prefer non-anatomical resection. And liver is divided into 8 segments. So anatomical resection is you take a segment out or combination of a few segments out. Non-anatomical resection is you just take out the tumor. And in most of the other tumors, we go for non-anatomical resection. But here in these tumors, again, I'm not going to throw all the evidence at you because there is a lot behind it, that anatomical resections are preferred. Children liver recover quickly. They're very good to retain their function, and they withstand anatomical resection quite well. Complete tumor resection, which is taking it out completely, a lot of debate about it because these are huge tumors. And for most of the cancers, we take about 1 centimeter of the normal tissue out. But for children, 1 centimeter is a lot. So the jury is still out on this, but the consensus now is that R0, which means a complete tumor resection with normal tissue margin, or even R1 resection. R1 is microscopic tumor resection margins are seen, does not alter prognosis. But we can't leave the tumor behind, which is R2 resection. So tumor has to be taken out, and microscopic involvement of the tumor is okay. It has got the similar long-term results as R not or a complete resection. Now, these are the new things which are coming up. I do lots of laparoscopic liver resection, but in a small child like this, in which tumor is size of the abdomen, you can resect that laparoscopically, but taking it out, you do a complete laparotomy. So there are very few case reports available about laparoscopic liver resection. We can't incise this tumor inside the abdomen to take it out in small chunks because there is risk of tumor seedling. So very few case reports are describing it in older children, but in smaller children, I don't know what the benefit is. So I've not done any laparoscopic liver resection for hepatoblastoma, but that is something which is being debated now. And a step forward, robotic liver resection has come in, which is a more fancy thing to talk about. But it's the same. It's same as laparoscopic liver resection, same issue of taking the tumor out, same issue of cutting the tumor and seedling it inside. So these are innovative techniques in which we are going to hear more about later on. Something which is not very common. I can only remember one case in which I've done it, but then in the literature, this tumor can push lots of structure, but you can easily separate those structure and take the tumor out. But occasionally, if there is involvement, find at the time of operation, we do take adjacent organs out, which is mostly the bowel or the stomach, which we can find attached to the liver. So it's a fancy thing which is talked about in large tumor in adult resection. And I'm just going to explain that slightly. A big tumor occupying whole of the right lobe of the liver, and the left lobe, which is very small, is spared. So in the first step, we tie the right portal vein. So all the blood goes into the left liver, and left liver grows very quickly. We incise the liver, but leave it inside the patient. So the first step, tying the portal vein, resecting the liver, but not taking it out, so that the rest of the liver tissue will support the body function, while the right lobe supports the function and left lobe regenerates. So in 1 to 2 weeks time, the left lobe regenerates and we take it out. So a two-step operation done for large, which were thought to be irresectable operation in adults. There are a few case reports in pediatric tumor, but I feel liver transplant is something which should be done in this case, and we are going to hear about this from Yasser later on. And still lots of other controversies. Second lobe laparotomy. So after surgery, are you going to go back in? So I think the answer is, if AFP is going up, then yes, you can go for a second lobe laparotomy. But now there are other things which can stop us going inside, like I've told you, indomethacin green, PET scans, all these things are there. But in guidelines still, it says that you can go inside if AFP level remain raised even after surgery. And I mentioned the lymph nodes are not involved in most of the cases, but if you feel the lymph nodes are involved at the time of resection, do not go for extended lymph node resection. We can do sampling just to confirm our diagnosis. So pulmonary mets, we talked about it, that the most common location of pulmonary met is lung. And traditional approach is resectable hepatoblastoma and lung metastasis is found at the same time. So pulmonary metastatectomy is done after resection of the primary tumor. So after hepatectomy, it is preceded by chemotherapy cycles. And children in which there is indication for transplant, metastatectomy that persists after chemotherapy should be resected before the transplant. So for resection, it's after the operation. For transplant, it's before the transplant. And then there are still questions open. There are still lots of controversies which we need to answer. That is chemotherapy alone enough to clear the lungs in patients undergoing liver transplant? Don't know the answer. And is there potential need for surgical exploration to confirm the clearance? We don't know the answer. It's such a rare tumor, so few patients, that these things will evolve if we generate the data together. Tumor rupture we talked about before, rare. Only 6 cases were reported. We can cause it. After biopsy, it can happen spontaneously or after trauma. And there are ways to treat it like we treat with any bleeding for these tumors. So I'm not going to talk about transplant here. So our transplant surgeon, Dr. Yasir, is here and he's going to talk about it. So, but that has opened up another big door for treatment of these rare but potentially lethal tumors. So we're going to go forward. Surgery is improving. It's improving quite exponentially. I've talked about some new innovative approaches which are coming up. So we need to keep an eye on them. Research and development is slow because of rarity of these tumors. But personalized treatment plan, which we are hearing about these days, personalized medicine or precision medicine is going to be future for all these diseases. Thank you very much.
Thank you so much, Dr. Irfan, for an excellent talk and being stick to the time. So we are going to invite our last speaker of this session, Dr. Muhammad Yasir Khan. He is an assistant professor and hepatobiliary and liver transplant consultant at Pakistan Kidney and Liver Institute and Research Center. He is a pioneer member of surgical team which have started liver transplant program at PKLI and so far successfully completed 760 living donor related liver transplants. And now they are running CPSP approved fellowship in this field. Dr. Yasir is talking about liver transplant for hepatoblastoma.
Assalamu alaikum and good morning to all. I first congratulate the Shaukat Khanum team and thank you very much, Dr. Rabia, Dr. Akila, Dr. Naeem for inviting me here. Yes. So this is the institution I come from. That's the National Center of Excellence for Treatment of Kidney and Liver Diseases in both adult and pediatric population. So we all know about hepatoblastoma, all the numbers. I won't go into the details, but it is the multimodal management that has actually improved survival, which is surgical techniques, including resection and transplantation, as well as chemotherapy. We have, excuse me, we've been hearing about them all the morning, and yes, these are the 4 groups. Now they've combined, and this is a trial which will make us probably more wise. So the previous 2 speakers, they referred to this CHIC and their risk stratification. So now what we know from analysis of their database is if you look at a few things, for example, as the pretext stage increases from pretext 1 to pretext 4, the survival decreases. Similarly, as the tumor becomes multifocal, the survival decreases. And as there is involvement of hepatic veins and portal vein involvement, all those annotation factors mentioned, so the survival, it decreases. Then the same findings from another, that's a very busy slide, from a Chinese 14 years retrospective study. And if you look at the risk factors, you can see that age more than 3 years, pretext 4 and metastatic disease. But the most important thing which I want to highlight is this: you heard about the margins, but if you look at this, that is macro PM, which means that they were macroscopically involved. It was not a complete resection. And this is actually 1 year survival in 3 and 5. You don't see any long-term survivors in this group. The number is small, but still no survivors in this group. While those who had microscopic resection, there were survivors in the long term as well. And the other thing is, as the vascular involvement, it increases, so does the survival decreases. And we all know these are the aims of liver cancer surgeries, which includes removing of the total liver and leaving enough liver behind, which should be sufficient for continuation of the human life. Now, I mentioned these all because transplant addresses all of these factors. How? These are the indications, and these are the conditions in which traditional resection cannot be done. So transplant, in which you remove the whole liver, these kind of tumors, they can be treated, which are multifocality, solitary pretext 4, which is involving all the 4 sections of the liver, centrally located pretext 2 and 3, those with portal vein or IVC involvement, recurrent tumors, and hepatoblastomas that do not respond to chemotherapy. So this is a patient, one of the CT of one of a patient whom we transplanted, and you can see there is such an extensive tumor involving almost all the lobes. So this is a pretext 4, and this is another image of the CT of the same patient. So no segment was spared. And then as I said, recurrent tumor. So you can see these are the clips. So this patient operated by us, she underwent resection, and now she has a recurrent tumor here and here. So multifocal recurrent tumor. She's on our, she hasn't, the first one, he has undergone transplant. The second one, she is on the transplant list, waiting for a donor. Now, if transplant can address all these issues, so what is the status of pediatric transplantation and is it safe? So now we know that worldwide more than 30,000 transplantations in children and adolescents, they have been performed over the last 4 decades. And data from different parts of the world, for example, if you look at this Japanese data of around 3,300 patients, the overall graft survival was 75.4% at 30 years. Similarly, this is the data from UNOS, North America, where you can see children who were transplanted in 2014 and 2016, and then they were analyzed after 5 years. So you see that the survival is more than 80% in all the age groups. This is from the other side of the Atlantic, the European data, which shows that the graft half-life is 31 years. And conditional 1-year survival, if you adjust it for those who die immediately and you exclude them, then that conditional 1-year survival is 41 years. And if you look at the transplant survival according to age, so the best survival is in this age group, which is less than 6 years. And that is precisely the age group that's being transplanted for hepatoblastoma. So, and the history of liver transplantation as a whole is, it started with pediatric liver transplantation. So this is the operative note from the first ever transplant, which was performed. And this was a 3-year-old boy who had biliary atresia. So that clearly reflects that transplantation as a treatment modality is well established and safe. And in 1984, it was concluded by NIH that transplant was changed from an experimental to a therapeutic status. Now, looking at liver transplantation for hepatoblastoma, these are some of the earlier reports, as you can see from the dates mentioned over there, though the number of cases, they are small. But at that time, even some of them, they had extrahepatic disease. But if you can see that majority of the cases, they were alive. For example, if you look at this series from King's, 13 patients, 12 were still alive. So these were some very early encouraging results. Then this SIOPL-1, 154 patients, and we know that amongst them, there were 12 transplants. And this is long-term survival data because this is reported in 2002 and SIOPL-1 that was concluded in the early 90s. So what we can see that for those who underwent primary liver transplant, the survival was 85%. But those who underwent rescue transplant, that is those who had recurrence or they required transplant because of the complications of surgery, survival was lower in that group, which is 40%. And just have a look at the timeline as well. That's more than 2 decades ago. Then 3 years after that, there was analysis of all the patients who had underwent liver transplantation till then. There were 147 patients. And yet again, the same thing was reiterated that in the primary liver transplant, the survival was much better, 82%. And in the rescue transplant, it was around 30%. This is the Kaplan-Meier showing us the same thing. These are the 106 transplants. You can see the better survival, while in the rescue, survival was lower. But over the last 2 decades, this has improved, and primarily because of improvement in techniques as well. So the data comes here. This is a multicentric Japanese studies of 100 hepatoblastomas who underwent liver transplantation. And you can see that those who underwent primary liver transplant, this is the 1-year survival touching around 90% and 88% at 5 years. And similarly, in the salvage liver transplantation, that survival has also improved, which was very low in 30–40%. That is now 81 and 76%. And another important thing was that the preoperative lung metastasis did not impact on survival according to their analysis. Similarly, if we look at the recent data from North America, UNOS, we see that there is 74% 5-year patient survival. So these are all the numbers which are clearly reflecting that liver transplantation for properly selected group of patients in hepatoblastoma is a very effective mode of treatment. Similarly, in transplant, we look at patient survival as well as the graft survival. So this is the SRTR, again, data from North America, which shows 72% 5-year graft survival in those who underwent transplantation for hepatoblastoma. This is again a very important slide. This is a split consortium, another consortium in North America looking at the pediatric liver tumors. And this is a very recent publication from 2022. So there were 157 patients in all the data amongst the roughly 2,500 patients who underwent liver transplantation for hepatoblastoma. And what they were able to identify was the 3-year event-free survival was 81%. Now, if we compare liver transplantation as a mode of treatment for different types of cancers in the pediatric population, so this is the hepatoblastoma and this is the HCC. EMB is the embryonal, where the number is low, like angiosarcoma, and METs, these are the metastatic tumors to liver, primarily the neuroendocrine tumors. So ignoring these small numbers, and we know that usually neuroendocrines, they have a very indolent course if they are low grade, but you can see that the patient and graft survival is much better for hepatoblastoma than for HCC. And that is clearly because of the difference in tumor biology. So because of these things, that it is an established way of treatment. This is the policy of NHS and where the organs are allocated by central bodies. So they are in priority list number 2. Super urgent is those who have acute liver failure. And after that, the second priority goes to patients who have hepatoblastoma in the UK. Similarly, in North America, UNOS, they are given priority by awarding them a higher MELD or PELT score depending upon the age, because PELT score is used till 12 years of age. And then they are given a status 1B, and this is a status which is reserved for the very sick, chronically ill patients, so that they can get a transplant very early. Hepatoblastomas, generally, if you look, they constitute somewhere from 4 to 10% of transplant activities worldwide. And you can see this was around 7.8% in 2011, and roughly the same 10 years later as well. Yeah, so that's another interesting debate, resection versus liver transplantation in a select group of patients whom we think, as Dr. Irfan mentioned in the later part of his presentation, was extreme liver resection. So some patients, they may be amenable to complete resection by doing extreme resection, which could mean taking the liver out, putting it again, the same liver, doing vascular resections, or we should just straight away do and go and do a liver transplantation. So on one side, we have a risk of incomplete resection. That obviously, the single most determinant of long-term survival is complete resection. On the other hand, we have the lifelong immunosuppression. So in some cases, the decision is not that straightforward. So there is no randomized controlled trial to guide us on the subject. There was a recent publication which tried to look at and find the answer. And despite a lot of publications, what they could find was that only 5 case series were of a substantial value to be analyzed in this regard. And when they, obviously it was not an apple-to-apple comparison, but when they did the analysis of liver transplant and liver resection, so you can see the overall survival rate, disease-free survival, tumor recurrence, complication rates in the published literature, they were roughly the same. Similarly, again, as I said, but yes, one thing which was noted was that those who underwent transplantation, they had huge tumors. They were mostly pretext 3, pretext 4. Again, the same thing from North America. They analyzed the National Cancer Database and compared hepatic resection, liver transplantation. Obviously, that was a different group to start with because of the tumor size. But you can see that overall, long-term, the survival is pretty much the same. And you can see in this publication from 2022, and if you look at this, despite all the effort, but if you, and development and advancement, so if you look at this statement that the COG liver surgical team is developing updated guidelines for conventional surgery versus liver transplantation in hepatoblastoma. So this is probably a subject of debate in some patients, and that is where the role of MDTs come, which I'll refer to. So this is a Japanese, taken from a Japanese study. And what they did was, if you look at these are the patients who were seen, and then a surgical team, they decided that this could be the appropriate approach for them. And then they underwent surgical central review and they were sent to transplant centers. So if you look, according to the initial assessment, 6 patients which they thought would require liver transplantation, but when they were referred to liver transplant centers, 4 of them actually underwent transplantation. Those whom they labeled as borderline minded, they were also trained pediatric surgeons, oncologists. Those 10 cases, if you look at them, amongst them only 2, they underwent liver transplantation. So this clearly reflects that there should be an MDT and collective wisdom should be used for these patients. Then another thing is timing of liver transplantation after the completion of chemotherapy. So prolonged chemotherapy administration in an attempt to make them resectable, it should be avoided. Usually the approach is to reassess patients after 2 cycles and 4 cycles. And if after 4 cycles, they are not responding, so probably they will require liver transplantation. But there was the Seopal group, probably they wait till 6 cycles as well. And this is important. Why? Because if we decide to transplant a patient, this is the North American data, that their patients, the waiting time was 1 to 50 days. They won't get the graft straight away. Similarly, there is a transplant evaluation process. This is our paper. And if you look at this, at 530 potential liver donors they presented, and amongst them 68.6% they were ineligible. And mind it, most of these rejections were not based on anatomical factors. So you see that almost 30% of the potential donors they actualize. So there's a lot of time required in deceased donor because they'll get a graft late, while in our setups, not everybody who presents as a potential donor will be accepted. So the FIT trial, which everybody has alluded to, now their recommendation, obviously, as a part of their study protocol, is that they have divided them into 4 groups, A, B, C, D. The group B, specifically B2, the high risk, they may be considered for transplantation and sent to a transplant center. Patient in group C, which are pretext 1, 2, 3 with positive annotation factors, which means an advanced tumor, or all pretext 4, they should be referred early to liver transplant centers. Early referral to liver transplant center does not necessarily mean undergoing a liver transplant, because the expertise are a bit different, and tumors which may not be resectable at another center, they may be resected over there as well. So pulmonary metastasis has been addressed, but I'll just point out to the fact that patients who have an indication for liver transplantation, pulmonary metastasis, they should show regression with chemotherapy, then they should be offered transplantation. And if they do not show regression, if they can be resected, they should be resected. These are the only 2 conditions in which transplantation should be done. If they persist and they cannot be resected, this is the subgroup whom should not be offered transplantation. Because if you look at this, apart from the general contraindication, so the only contraindication is the for hepatoblastoma is the presence of any active regional or distant metastatic disease which is not cleared by chemotherapy or surgery. Tumor rupture, it has been referred to, but what this study showed that they actually transplanted 3 patients who had initially liver tumor. And what we saw is that at follow-up of 3, 8, and 9 years, these patients, they were doing pretty well. So this is very impressive. Similarly, for tumors which are invading into the portal vein, into the IVCs or adjacent structures, there are reports. You can see this is multivisceral transplantation, that you go out and go in and take out the liver along with the stomach, duodenum. So yes, there are case reports, not very robust data supporting it, but we can see some pretty much good survival of 4.5 and 7.8 years in this subgroup as well. So what are the risk factors for recurrence? Obviously, this is what the Japanese data is showing us. And the only thing which has been validated elsewhere is this, that a high rise in the AFP level after transplantation, which is suggestive of a recurrent disease. Otherwise, the rest of these things, they were not validated in studies done elsewhere, primarily in the West. So this is actually a transplant pathway. The patient, they come, they are evaluated in the clinic, then MDT, and then their listing meeting and transplantation. Recipient undergoes a workup. That's why it takes time. And this is the guiding principle for transplantation. This is known as the principle of triple equipoise, that we have to adjust need, donor safety, and the recipient outcomes. Something about the surgery, that there should be early vessel ligation, portocaval shunting, so that the blood flowing through the liver is decreased. And if required, IVC and portal vein, they are replaced. So these are some of the surgeries which we have done. This is a picture from a donor surgery. You can see normal liver split into two. Usually this part goes to the children. And this is what is done in the West, but this is the only one done in Pakistan, which we did is a split, a deceased cadaveric liver, which is split into two, this for adult and that for child. So this is how the liver graft looks on the back bench, and these small structures, they are anastomosed. This is an IVC replacement, and this is how the transplanted graft looks within the body. So I'll just go through a case, which is I don't know, do I have time or? Okay. So this is a case of a 6-year-old girl diagnosed with hepatoblastoma, biopsy proven fetal type, pretext 4, annotation factor P positive. You can see over here, the portal vein is completely obliterated. AFP was 20,000. And then this is the post-chemotherapy. She received chemotherapy with cisplatin and doxorubicin, and we see a response. AFP has decreased. We see this is now pretext 3, but still P positive. The size has decreased. Obviously, this is not the whole scan. So discussed in MDT, and she underwent a living donor liver transplant on 13th of September 2022. Histopathology, it revealed the important thing was this tumor thrombus was noted in the portal vein, both macroscopically and microscopically. Obviously, it doesn't refer to the margins, which were clear. And this is the surveillance scan 1 year post-transplant, and the AFP was low, so there was no recurrence in this patient. Regarding transplantation, yes, we have seen about the long-term survivals, but it has its risk of complications, and that come from the transplant surgery itself, obviously from smaller children and those who are undergoing transplantation after chemotherapy. So there is already nephrotoxicity induced by the chemotherapy, as well as the bone marrow suppression, which is induced. And we did struggle with one patient whom we resected because of the low counts. Some long-term challenges which we see, primarily the immunosuppression toxicity. These are the long-term challenges which we see in all the pediatric transplanted patients. And yes, now this is a new dimension which is added, that yes, I showed the figure as well, impressive long-term survivals, 80%, 90%. But if you look at a meaningful survival, them going back to a proper meaningful life, and this is one study which compared them. So if you compare them with, these are patients who are 20 years post-transplantation, and they are compared to national data of 16 to 24 years. This is from the UK, normal peers. So if you look at this, anxiety and depression is roughly the same, but those who are not in education or employed, you can see 26%, while 11.3% of the normal population, they were unemployed. Learning difficulties were more, around 13%. And if you look at the BMI, that reflects their weight and growth as well. And most importantly, 9% of the patients, they had developed stage 2 CKD as well. So yes, it comes with these challenges as well. So what we have done so far, we have done 20 cases, and amongst them, there are 4 living donor liver transplantation, and the rest, as Dr. Irfan mentioned, every kind of resection from removing right liver to left liver to the right trisectionectomy. That means roughly 3/4 of the liver is removed. In order to facilitate our patients, we have this program, which is known as the paired liver exchange. If they don't have an appropriate donor, since in Pakistan, somebody who is unrelated, they can't donate. But if they have a donor from another group, so we can put them in a swap with another pair as well. And then this is a discussion which is always done, that how is living donor liver transplantation doing versus cadaveric liver transplantation. So surprisingly, which is quite opposite from the adult population, in pediatric population, we see a 42% decrease in the risk of death at 1 year. And as I said, we look at the survival and graft functioning. They were much better with living donor liver transplantation as compared to pediatric transplantation. So, thank you very much.
Thank you, Dr. Yasir, for such a wonderful talk. Now we can move to the question answer session and panel discussion. And the panelists include Dr. Taur Rahman, Dr. Irfan Ahmad, and Mohammad Yasir Khan. Question and answer session, there any? Yeah, yeah. So everybody can hear your question.
Thank you very much. This was a fantastic session. And I think something that we, kind of, it's always been at the back and not come at the front. And this time, the SKM made it hepatoblastoma first session. So, that it just goes to say that it is a very important part and a challenge for pediatric oncologists always. So starting, I mean, Dr. Yasir, that was a fantastic, presentation, and it's nice to see that liver transplants and liver specific surgeries are now starting. My question to you is that, I mean, it was really kind of surprising to see that around 2/3 of your donors were ineligible. And I know there may be multiple reasons, but is there like a group, what were the main reasons? I mean, these are like 2/3 of healthy adults going on with bad livers.
Yeah.
Or
No,
that is a
yeah.
surprise. And also, there was a second question, but anyways.
So, yes, that is what actually happened. I mean, Dr. Irfan is here. We are not boasting about it, but we have accepted donors who were rejected elsewhere on the basis of anatomy. It was not that they were unhealthy or they couldn't become donors. Because it's a voluntary altruistic donation without any pressure. And once they are informed about the whole process, it is their sweet will whether to proceed or not. So in majority of the patients, roughly around 45%, it was because the donors themselves, they withdrew. That was the reason. But yes, what we are seeing, which is not, I think, relevant for this forum, that is, we are really seeing fatty livers and apparently very normal looking and very healthy with normal BMIs. So yes, MASH, as it is known, the fatty liver, that's a new pandemic. So that's coming big time as well. But most of those donors, they undergo a dietary program and exercise program, which we have at our hospital. And most of them, they're able to reduce the fat content in their liver and they can become donors. But obviously that requires time. So one of that patient, which I saw, which I just shown with recurrent hepatoblastoma, she came up with a donor who is apparently normal, BMI 23, but has S3 steatosis, a lot of fat in his liver. So he cannot become a donor and he's currently in that program. So we may have that luxury in elective transplantations, but in sicker patients, in cancer patients, we don't have that luxury.
Yeah, well, that's nice to, I think that's a very important finding, and this has to be like communicated because yes, fatty liver is a huge problem. So the follow-up question on that was that what is the status in Pakistan and as a transplant as a whole about disease donation? I know there's a lot of it's going on. So if you could just update what's the
Yeah, so
present
disease-
status, and I think it's also provincial wise different, is it?
No,
Or it's a national?
obviously disease donation, if there, we have performed 3 cadaveric transplantations. And in Pakistan, over the last 12 to 14 years, only 4 cadaveric liver transplants have been done. So the 3 which we have done, we got 1 liver from UAE. So obviously that donation happened elsewhere. The 2 livers which we got, they were from Rawalpindi and they came from very motivated families. In one case, the donor's whole family, they were doctors, very well educated about the subject. And in the other case, similarly, most of the family members, they were doctors. Elsewhere, yes, we are part of it, but there practically there is nothing happening because there is a lot of resistance. We can't figure it out whether there are religious reasons or cultural reasons, but there are a lot of barriers to donation. And if you look at the rate, that is less. I mean, our total number of transplants, probably today we'll be doing a transplant number 779. And amongst them, there are only 3. And that is, in one case, we were like super lucky. I mean, we got a liver from another country, which is just almost unheard of anywhere in the world. And the 2 cases I said, they were exceptional families. So for general population, there is a lot of resistance and a lot of work needs to be done in that area as well. With regards to provincial, there are provincial regulating bodies for transplantation, but they all regulate them under the constitutional framework. And there was a federal, by the federal parliament, that was an act of parliament, and the same has been adopted by all the 4 provinces. And then they have their own interpretation, which is known as rules and regulations. So yes, provincial bodies are regulating it, and they're also pushing and educating people, encouraging them to become donors. But practically, I think a lot needs to be done in that regard.
Just out of interest, the living donors, are they parents usually or brothers and sisters?
Yes, so they need to be relatives, number one. And usually the relatives are of 2 types, close and non-close relatives. So close relatives are defined by the law as parents, siblings, and husband and wife. And of course, children as well for the adult population. What we see is in majority of the cases, yes, they are usually close relatives, more than 60–65%. But non-close relatives, which mean any relative, can donate.
Just a disclaimer, I'm not a pediatric oncologist. I'm a nuclear physician. I just want to know, how does indomethacin green work in terms of detection in the liver? How do you detect it? Because you don't, I mean, I'm used to detecting radioactivity. So how does that get detected if the organ is not open? How do you see it? Are there readers or scanners?
That's something which is coming up. It's quite a new thing. So in laparoscopic surgery, when we operate, we can see that. So there are certain cameras have got detection system. So what we do is we change the mode and everything turns into green and black. So we know where that green is. So that happens in laparoscopic surgery. For open surgery, you require special type of cameras in the operation theater. We are not using it in our hospital as yet. And I think in Pakistan, it's not being used. But in many of the operations, even simple operations as cholecystectomy, it is being used routinely in most of the countries. So it's an upcoming thing. Mentioned that in hepatoblastoma, I think it was Yasser who gave me this information, that it's a unique characteristic that indomethacin does not clear up to 24 hours. So even if you give it the night before the operation, we can pick it up where hepatoblastoma is. So it has got huge uses. I hope that in Pakistan, this will be available. So it's an upcoming technique. But special cameras are in the laparoscope.
My question is for Dr. Yasser. How much time is taken from referral to the transplant at your center? So what is the right time we refer patients to you? So their transplant is done timely.
So as I said, and I had shown you, donor selection, it requires time. But usually, if all all things are straightforward, it takes around 3 weeks, because there is a donor and recipient assessment and evaluation process in which they undergo certain tests, as well as their evaluation by other specialty doctors like cardiologists, pulmonologists. And after that, they need to have an approval from a hospital committee, and then they are presented to that provincial regulatory body. And once we have approval from them, then they undergo transplantation. But this process can be expedited depending upon clinical urgency. For example, in certain acute liver failure and acute and chronic liver failure patients, we have transplanted them within 24 to 36 hours after initial presentation. So clinical urgency dictates the time required, but in the routine elective cases, it takes about 2 to 3 weeks. But if they have problems, like for example, What we struggle with is infections and donor selection. If donor, for example, a donor turns up and he's a smoker, so we need some time to quit smoking. Similarly, if there is fat in the liver, so many different fluid factors are there, but usually that's the timeline.
So my comment is for Dr. Irfan. You said that most likely there are only 2 surgeons in this hall, but I would like to assure you that for oncologists also, it's very fascinating to know how the advanced surgical techniques are being used in the management of patients of hepatoblastoma. And talking about LMIC countries, so it's very sad for us as an oncologist. So when we give neoadjuvant chemotherapy and when the time of surgery comes and the patient has very extensive disease and tumor is not resectable, and then we face challenges to convince families to go for transplant. So yeah, we are seeing many patients in our setup, those who doesn't have resectable tumors, and then initially family doesn't show willingness to go for the procedure of transplant. And obviously there are multiple factors. So hopefully with advancement in surgical techniques and going further progress, there will be better outcomes for our population also.
A comment on that. I think that's a very important point you have raised. I think our population is very diverse. It's very unique genetically, but we act on all the data which comes from the West. So our own studies, we don't have our own numbers. We don't exactly know what the epidemiology is. I think our numbers are much higher than the West because hepatoblast, when I was in UK, we used to see rarely 1 or 2 cases a year. Here in Shaukat Khanum and in PKLI, we see them very regularly. So our number of cases is different, epidemiology is different. So we need more research coming out from our own country, which is not only epidemiology, but also all the trials which we have seen. I think our name should be there in those trials because we need to look into our own population set. So I totally agree with you. And I think that's why we might pick up that our treatment protocols might be different to what we are following already for our population.
And I was going to comment that, like for most tumor types, I think for hepatoblastoma and hepatocellular as well, when you've got a transplant service available, right at the outset, if you've got an MDT where high stage tumor, first of all, I think guidelines need to be discussed as to who qualifies for transplant consideration. So at the outset of the MDT discussion has been had, and then you can decide whether, this is the timeline for this patient to be transplanted. So that process is facilitated, and the time lag that you're talking about, of course, if it matters, sometimes in the UK, when you're waiting for cadaveric donor, 3 weeks or even more, sometimes, it's spent. But in any case, to facilitate the whole process, I think an MDT at the outset, and what you said was, to begin with, we need to have our own study. So I think that kind of MDT can facilitate the trial.
Yes, I would like to make a comment as well. We had a hepatoblastoma conference in February this year, and then we decided that all the centers will collaborate and we'll come up with national guidelines. We did a similar activity for hydrocolangiocarcinoma, but then unfortunately, I think everybody got busy. So yes, I think we should just go and start working on that. And I guess we'll have some meeting after 1 week because we at our hospital are quite busy with our GCI accreditation, which the survey will start from Monday. So once we are done with that, inshallah, Dr. Sadia and Dr. Rabia and Dr. Mavish, they were the leads. So we had one Zoom meeting as well. And I think the aim is to come up with a summary of evidence. And then, as Dr. Irfan said, maybe our contribution to international literature based on our local data as well. Thank you.
Thank you so much, Dr. Yasir. Just responding to yes, we are working on this, and inshallah, we're going to have this soon. And for Dr. Irfan, just to have the comments, yes, we have our own data. We have much bigger number rather than the West, and they are we are seeing more than almost 30 to 40 cases per year. at our center. So we are collaborating, and soon we'll be able to have our own data and registry on that. And I'm looking forward for this, and that will obviously improve the survival of this kid. And this is the only the way is the collaboration that we can improve the survival of these kids. And the one thing again, what we want that we usually used to send our patients who are just planned at the beginning after the MDT at our own center, that they are probably the candidate for the transplant. We used to send at the onset just to initiate the process so that they have the less time for their ultimate treatment. So we are looking forward for that. So if there is any other question, okay.
I just wanted to ask, it takes time for a patient to be identified as hepatoblastoma in many centers, and then go to an oncologist and then being referred. This time takes, this is about a adequate amount of time in which the patient is deteriorating. Do you see patients that come in quite late to your center for hepatic transplants? And if they are patients for candidates for transplant and they are waiting for the donor to be adjusted and selected, is there any role of any surgical procedure in the meantime for them to improve their quality of life? Because they have distension, they can go into INCAF because of the jaundice levels and etc. and so in fact. So is there any role of surgery during that 3 weeks, 6 weeks, maybe more? Just wanted to know.
Yes, so I mean, ignorance is a major part of our society. I will just tell you, recently we had a patient. That patient was treated at Children's Hospital 3 years ago, very resectable tumor. The patient was sent over to us for an opinion, and probably he never got the opinion, and they left on their own accord without informing the Children's Hospital team as well. And 4 years down the line, the same patient presented to us with the liver studded with tumor as well as bony mets. So yes, we see there are a lot of factors. I mean, apart from delay in diagnosis and referring them to the appropriate centers, be it oncology, surgical resection, or transplantation, we see a lot of resistance and I would say ignorance on the part of the families as well. Regarding the second part of your question, any procedure, there is, if I have understood your question correctly, if you are referring to hepatic encephalopathy or ascites, so there is no surgical procedure. They are actually managed conservatively. In some patients, not in hepatoblastoma, there is no data out there, and not in the pediatric population, but for ascites or portal hypertension, which usually occurs in cirrhotic livers, not in this population, there is a procedure which is known as TIPS, done by the interventional radiology, that can be done to relieve the pressure. But obviously, they usually have normal livers, so they don't come up with ascites. And despite portal vein thrombosis, we don't see them presenting with upper GI bleeds or having massive varices. And as such, there is no surgical procedure which can actually help in the interim period.
I want to thank all of you for a fantastic talk. I'm not a hepatoblastoma person, but I thoroughly enjoyed it. And, you know, we've been talking a lot about data from Pakistan itself. And I think that's the journey that we've already started through the Pakistan Society of Paediatric Oncology in collaboration with other societies, ophthalmology and neuro-oncology, etc. And I think that's the way that we really need to work forward in there. At this time, we're working on a centralized registry. Alina is actually leading that project under Pakistan Society of Pediatric Oncology, and especially for rare tumors like hepatoblastoma. Collecting all that information and data that comes through is going to be key in terms for us to understand whether our patients are behaving the same as other patients that we see. So I think, really, this is fantastic that we're all sitting here talking about exactly the same thing, about collaboration, about centralized data collection, about looking at things scientifically and taking it forward. So thank you.
Quick comment on that, and I think that's a very important thing. Data collection is what is happening now, what has happened in the past. So in our hospital, we are in the process of setting up a biobank in which we are going to store those samples. So that will be available for future researchers doing those all genomic studies. We have seen those studies in the presentation, those genomic studies, but they have not come from our countries. They have not come from Asia. So that's, I think, where we need to start. So those databases will feed into our biobank. At the moment, it's our own hospital biobank, but I think in future there should be a national biobank in which these things are stored, and then these things are carried forward for our researchers. As doctors, we do not interact with our basic scientists. They do all the research in a lab and we work in clinics, and there is no collaboration between them. So that's what we are trying to develop right now. I've just been to Qatar to see their biobank. It's a fantastic project, but Qatar do not have the population to fill in that biobank. Their population is 100 times less than ours, and we don't have a biobank. So I think with collaboration, we can work together to answer these questions.
Set up a pediatric nearby.
Excellent.
So I think this is, and again, at this point in time, it's very only a big, but the setup is there. We get more funding to expand that to other centers.
And I think that's where these things should work in collaborations, because then we can actually expand our scientific understanding.
Thank you. So here we're going to finish over this session, and I would like to thank all speakers and all participants for this. Thank you.